Good morning, one and all. Warm welcome to all the participants as well as the guest speaker of today's session, Dr. Krishnaya Garlapati.
Thank you. Good morning to everybody.
So, on behalf of Chalapati Institute of Health Sciences, I welcome Dr. Krishnaya sir for this wonderful session on the medication therapy management. And I request Arnika to give a brief about SARS CV.
Good morning, sir. I'm Arnika of 4x6 family. I guess it's late
Good
night
morning.
for you.
Still good morning to you. Yes.
Thank you, sir. I'm here to introduce a bio about our speaker, Dr. Krishnaya Garlapati. He's an MD of internal medicine specialist in Tiffin, Ohio. He's affiliated with medical facilities Mercy Health, Tiffin Hospital, and Pro Medica Toledo Hospital. He has got 21 plus years of experience, education and professional training. Sir is graduated in Kurnool Medical College, NTR University of Health Sciences Medical School. Sir has done his residency in Lutheran Med Center and Cleveland Clinic Foundation for internal medicine. Certifications and licensure. Sir was licensed in Ohio State and is active through 2023. Sir has received and achieved various awards in Pro Medica Toledo. As mentioned earlier, with Sir's experience, the hospital was received an award as one of the top 50 America's best hospital. Sir has also received a CMS stage, where it means Centers for Medicare and Medicaid Services and Electronic Health Records. So he's been received award in 2011, 2012, and 2013. Publications. Sir has done publications on adult with interstitial deletion of chromosome 10, overlap with Coffin-Lowry syndrome. It's a rare genetic disorder characterized by intellectual disability, abnormalities of head and facial area, large soft hands with short, thin fingers, short stature or various skeletal abnormalities. The characteristic facial features may include underdeveloped upper jaw bone, a broad nose, protruding nostrils, an abnormally prominent brow, slanting eyelids, and widely spaced eyes, large low-set ears, and unusually thick eyebrows. Patients experience accolades. Sir spends appropriate amount of time with patient and provides thorough examinations. Sir has top marks across all patient-rated categories. He's rated highly on matters of manner and listening skills. Sir is recommended to the patients of their friends and family. The previous patients trust in physician, likely to see this physician again. Patient satisfaction with physician's treatment of a condition or outcome of a procedure. Patient's assessment of this physician friendliness and caring attitude. Thank you, sir, for accepting our request and making time for us and deliver this webinar. I hand over this to sir.
Thank you, Arnika.
Thank you very much.
Sir, it's for you, sir. You can start your session, sir.
Okay. Well, my introduction sounds like somebody else must be introduced. All those things she was talking about, they seem kind of foreign to me. But today, not being a professor, not being used to teaching students of any kind on a regular basis, I thought I would introduce my set of skills that I use or used to use as I am retired now for the last year, and see if it might make some sense to you and if it would help you in any way. So in US, internal medicine specialist basically is somebody that is taking care of adults, but not pregnant women, etc. So we become caretakers for chronic diseases. So it could be chronic hypertension, diabetes, COPD, heart failure, and many, many other things. So I think it so happens diabetes became so common in the US. We deal with it every day practically. And along with the diabetes, a lot of hypertension and a moderate amount of heart failure and chronic lung disease, etc. And one of the things that helped me in my career is understanding the most important part of my job. The most important part of my job is not my stethoscope, my office, the computer system. It is the patient. So if I can do what is right for the patient, then I would have done what is right for me, and everybody benefits from it. So if you learn nothing from me, I want you to learn this. The single most important aspect of our professional life is that patient, irrespective of the fact he's not paying any attention, he's not following your directions, he still smokes, he takes medicine as he wishes, he doesn't keep his appointments, but that patient is still the most important part. If you do it just strictly for the money, strictly for the next promotion, or strictly to finish the day, I think you miss a lot. So that's number one. Number two, the patient tells you, if you give them a chance, everything you need to know or you want to know. So typically, it takes 19 seconds for a medical professional to interrupt what a patient is saying. So we typically ask the patient, what is the concern or what is your problem? And before they say anything substantial, we are already asking them the next question, or we are telling them the next thing. So that becomes a bigger problem. So I see Sandeep is there.
Yes, sir.
Yes. So do you want to open to questions, or how do we want to do at this point?
At this moment, you please let me know your experience around the heart failure, diabetes, hypertension, and everything, the cases which you have seen, and let them know some basics, sir. Then we'll open to the question and answer session, sir.
Okay, so let's talk about diabetes.
Yes, sir.
The diabetes is highly prevalent in this country and even in India today. I think India has about 70 million cases of diabetes, second highest in the world after China. So the most diabetes we see is the type 2, what we call as adult onset, maturity onset, etc. Mostly older people, but more and more younger patients are there, sometimes teenagers. And one of the worst problems is they had diabetes for some years before you find out. So, in other words, by the time you made the diagnosis or somebody made the diagnosis, they already had the diabetes, maybe sometimes as long as 5 to 10 to 20 years. So the problem is not making the diagnosis at this point, but trying to find out if they have any eye problems, if they already had vascular problems around the heart, in the legs, if they have neuropathy, if they have any gastrointestinal problems, or what all the other issues. I think it is customary among doctors and probably other professionals to jump on a medication because we found a diagnosis, we want to treat right away. My response to that is most medications could be fraught with danger if we don't know the biochemical status of this patient. So the thing to do might be draw the right blood, blood for the right test, the A1C, the chemistries, the lipids, the liver functions, and get the urine for microalbumin, routine urinalysis, the protein, etc. And then bring them back in a couple of days, and then you would be able to start the appropriate medication. And I have seen patients who are blind first before they knew the diagnosis of diabetes. I've seen patients who came in with a heart attack before they knew they had diabetes. We have seen patients that are ready to lose the leg before they had the diagnosis of diabetes. And this doesn't often happen this way in type 1, but in type 2, this becomes very common. When it is common in US, I bet it is more common in India. And so the next associated problem with this is hypertension or high blood pressure. You could have diabetes with high blood pressure or without, but when it is with high blood pressure, you got a slightly different set of problems. And if you have a patient with congestive heart failure or heart failure, as we call it today, with or without hypertension, or with or without coronary artery disease, that poses an entirely different set of problems, oftentimes in the therapeutics and how we manage the patient globally. And because I have seen patients, not once, twice, same patients for 20 to some cases 30 years, get to know the patients and get to manage them. Unfortunately, that may not be the case in India today. So you can see progression or deterioration of the patient over many, many years. And interestingly, you'll see the father sometimes the grandfather, the son, and the grandson over the last 30, 40 years. And so you have a good understanding of what's happening in the family and in the patients, because you knew the previous generations, what you can expect in this patient going forward. And the next issue is, what do we do with the medications? The area of the country I was in is a poor area, and employment rate has been affected. So they don't have their ability to buy the newest, most expensive medications. So we have to learn to deal with medicines that have become generic and are available much more cheaply, but still work well. And how we go about using them alone, in combination, and always mindful of what are the serious consequences and complications that are coming. Because as you all very well know, every drug has numerous side effects and complications. So how do we go about paying attention to that and prevent the major complications? So I found, in spite of the fact that we use a lot of modern medicines, we still go-to medicine is still the metformin. The go-to medicine is still ACE inhibitors, ARBs. And in our prior discussions with some of the faculty, I found you guys use a lot of digoxin there. And my last digoxin for congestive heart failure was probably 15 years ago. I think I have one patient, as I retired, on digoxin for a supraventricular rhythm disturbance, and that was the only medicine worker for him. So it's not just it is a fashion not using digoxin, but it is like what are the risk factors if we are on digoxin at this point. So most of our cardiologists in the area I practice will not use digoxin because the therapeutic window is so narrow, and drug-drug interactions, the side effects, and the fact that it really doesn't do a whole lot other than maybe decrease the hospitalization by just a tiny bit. And I know many doctors, even including cardiologists, don't always use a statin or an ACE inhibitor in people with heart failure in parts of the country, in India. We find it very difficult to manage a patient without being on an ACE inhibitor, a statin, if you have diabetes. And I have had patients with the diabetes where they were not on any medicine for diabetes, but they were on medicine for the other comorbidities that seem to almost always follow them, the heart and the high blood pressure and the kidney. So I often tell our patients, if you have diabetes, you have a heart condition, meaning the risk of heart attack or cardiac disease is greater than that of a non-diabetic that already had a heart problem. That is a heavy load of cardiac disease on somebody with a type 2 diabetes. So what do I do if you have heart disease? We treat you with a ACE inhibitor, we treat you with a statin to decrease further consequences or further attacks of coronary artery disease. So the same thing we do in people that have diabetes. So much so, I would used to get questions from insurance companies if somebody did not get their statin filled or did not get their ARB or ACE inhibitor filled. Doctor, how come you're not treating the patient with this group of medicines? Because the data is strong that statins, ACEs, and ARBs reduce the risk of premature death in these patients. So I think if you start looking at not just what is being done in Andhra Pradesh or in India, but globally in the current medical literature, the data is clear for 1, 2, 3, whatever is making sense. That's what you guys need to be following and promoting to your doctors, your hospitals, to do the evidence-based medicine. And I think that becomes the most important thing. When there is no evidence-based medicine, you're not helping anybody. So we all have to go back to that evidence-based medicine. Whether it is digoxin and congestive heart failure, whether it is ACEs and statins in diabetes, or treatment of chronic neuropathy with the narcotics. There is no data to help the narcotics, help use of narcotics in these patients. So evidence-based medicine and patient safety, those become the driving force behind you. So I would open to any questions anybody have. I don't hear anything.
One second, sir. Students are coming.
Okay.
Good morning, sir.
Good morning.
What are the major risk factors that cause CHF in most of the patients that you have seen?
I missed a part of that. What is the risk
Major-
factors?
In CHF patient that you have seen majorly?
The most common risk factor is coronary artery disease. Number two, hypertension. And number three, complications of diabetes, or sometimes the medications. But number one is the coronary artery disease. Either they had untreated ischemic disease, or they had a myocardial infarction, or the stents, etc., failed, or that is the number one. But in India, at least when I was in medical college in India, the number one cause at the time was mitral stenosis was the number one cause for people to go into congestive heart failure. I think that must have changed because I left in 76. Now it got to be more coronary artery disease, even in Andhra Pradesh at this point.
Okay, sir. I had another question.
Yes.
What are the problems you faced during counseling session?
During what?
What are the problems you faced during counseling session? Could you please share about your experience that might help us to become a competent pharmacist?
Okay, because sometimes it's not, sometimes it's too loud and sometimes it's too soft. So, did you say confrontation?
Sir? Patient counseling, sir.
Oh, patient counseling. Okay. I find, I think the patient comes with the idea, at least here, the doctor is going to tell me the same thing again. I need to lose weight. I need to quit smoking. I need to exercise. Oh crap, who is going to do all this? Everybody told me to do this for the last 20 years and I cannot do it. The diet, everybody, they basically think you cannot eat this, you cannot eat that. And the medicine, you have to take it exactly what it says. So the patient feels that he or she has absolutely no control. And they're only coming to see you or me or go to the nutritionist just because they are forced to do that. When somebody is forced to follow a diet or a medicine, it is unlikely they will follow that for any length of time. So I don't want to say that all my patients always listen to me. No. Some would openly say that, but oftentimes I know because I saw the patient walk in, put the cigarette out right outside my office and tell me inside, oh, he quit smoking a long time ago. So they're not always listening to you. And our special training tells us we have the knowledge, they are paying money, and they should learn to listen to us. That does not happen. So what I tell you is, number one, if your patient listened to you first time, you are very lucky. We generally think patient is lucky he is listening or she is listening, but the patient is giving you a rare compliment by listening to you the first time. If you gave him 3 different advice, if he or she followed one of them, I'll say, hey, thank you for doing this. You followed one, very important. So let us see if we can do the second one. Come back, talk to me next month or next week, whenever. So you are not going to accomplish everything your book says you should do, or your boss says you should do. You should counsel the patient, cut back the salt, take the medicine like this, and exercise every day, follow the diet. Nah, it ain't happening. So you take it step at a time. Because the patient didn't get this way in a year, in a month. Oftentimes it took him 20 years to get there. So you're not losing much if they did not follow you or advice in the first week or first month. But if you can thank them, encourage them for what they accomplished already, you're going to get your point across. They will listen to you.
Thank you, sir.
You're welcome.
A very warm good morning to you, sir.
Good morning.
My question is, as you discussed, evidence-based medicines are important to treat, but if evidence-based medicines are contraindicated or allergic to the patient you are treating, then do you prefer evidence-based medicine or any other alternative drug?
Okay. Well, let's take evidence-based medicine. When you follow the evidence, there are almost always more than one drug in that evidence-based schedule or the algorithm. They said ACE inhibitors for heart failure, for example. I have seen enough problems with ACE inhibitor in my practice, hives or angioedema, rash, itching, high potassium, etc. So what do we do? We take them off the ACE inhibitor. You wait a week, 2 weeks, a month, then bring them back and say, hey, I know you are allergic to this. Let us go to an ARB. I mean, angiotensin receptor blocker. Maybe some losartan or valsartan. We'll start on a small dose, check your electrolytes, or if you have any problems, call me, come back to see me. If you start somebody on insulin for diabetes, they had hypoglycemia, or they had a localized reaction at the injection site, I want to tell them it's not an allergic reaction, just a local reaction. Maybe try a different site, maybe change the technique. Or if the patient is reluctant, maybe change to a different insulin. It might help me to answer your question better if you throw in some names of what were the drugs involved or you're concerned about in the recommended drugs that you're not able to use.
Sir, did you give any other, some other examples, where we can put into the practice in general hospitals in India?
I mean, there is always more than one line of medication. For example, metformin is indicated across the board unless you are very elderly, like 80 years old or older, or if your kidney function is poor with a creatinine of 1.6, whatever, and that patient is falling right on the borderline, you're afraid to use it. Okay. So then you want to be looking at what other medicines within reason the patient can use. Sometimes an old-fashioned insulin may be a better way. It may not be on the evidence-based medicine for the type 2 diabetes. I'm not sure what are all the drugs available in India for the type 2 diabetes and the cost is, but if they don't have congestive heart failure, if they don't have any dependent edema, Avandia and a group of drugs like that may be a possibility. Now there are so many different classes of medicines available to treat diabetes. If you want to treat congestive heart failure and you have evidence-based medicines, either the patient don't want to use or the only medicine he want to use is the furosemide because that's what his grandfather used, his father used, and that's what he wants to use because it's also cheap. I would tell him, yeah, that's a good medicine, but it doesn't change your mortality risk. Here are other medicines that actually have been shown to improve your mortality. You're going to live longer and healthier, so why don't we add other medicine that actually show the data? My way of looking at it is, you're at the train station, the train to Chennai has left, so you say, oh hell, now I'll go to Kolkata and get on the next train. That would be like you taking the alternative when the evidence-based medicine is not available. But most of the time, the evidence-based medicine has an alternative that is quite acceptable. I know you would have to probably argue your point with the doctor there. And that's why everybody need to be familiar with what are the current recommended drugs or therapies by that particular specialty, whether it's the Cardiology Association or ACOG or Endocrinology Association or American Diabetes Association, whatever the case may be. So that becomes an important thing.
Okay, sir. Thank you for your answer.
You're welcome. I am not sure I gave you the answer you're looking for, but that's what I could think of.
Good morning, sir.
Good morning.
Sir, I'm 2/6 family. In treating coronary artery disease, in our prescription, we'll be seeing tablet aspirin and tablet clopidogrel. Both are antiplatelet agents. Can you please tell any added advantage using two antiplatelet agents?
Okay. Typically, no, there is no advantage. Clopidogrel probably has better protection than aspirin. When you combine aspirin and clopidogrel in a non-intervention patient, meaning did not have a stent, did not have an open heart surgery, there you are quadrupling the risk of bleeding and without any significant benefit. My practice has been, if you have stable angina and you are doing well, you will be on a low dose aspirin. If you had a angioplasty and a stent done, then for the first 3 months to 9 months to a year, depending upon which cardiologist, you will be on probably on a clopidogrel or one of the similar medications. And if in the first week or two of after intervention, we have seen a lot of physicians wanting their patients on both aspirin and the clopidogrel because there is a slightly increased benefit. But after that, there is no further benefit. You are.
Good morning, sir.
Good morning.
Sir, is my voice clear, sir?
Yes, yes. It's not you guys' problem. It's my old ears that are the problem. Just so you know.
Sir, after if an individual after affecting with COVID, sir, they'll be using steroids, no, sir?
Why?
Steroids.
Why? Where is the data that shows they need the steroids after the COVID?
For some people, they prescribe it steroids, no, sir?
I know. See, that is one of the problems. India, particularly, everybody is on a steroid after the COVID. And so India is one of the very, very few countries that had the highest incidence of mucormycosis. So a small dose of steroid has a benefit, but India has given large amount of steroids for a long period of time. So when the patient is off ventilator, are recovering, there is no further benefit of being on a steroid from what I understand. My experience with the COVID is limited. I retired as the COVID was becoming more prevalent. But I'm not sure I follow that because the mucormycosis cases have gone up markedly. Am I right?
Sir, but in India, mostly they use it, sir, steroids.
Right.
Sir, because of steroids, they will be causing diabetes, no, sir? Means increased blood glucose levels in patients. So will it become permanent or temporary, sir? If they stop using steroids, will it become, means will the diabetes be, will the blood glucose levels be decreased, sir, in those patients?
Two things. Number one, if the patient has strong family history of diabetes, if they're obese to start with, and you use not terribly high doses, but modest doses, and they start having elevated blood sugars, then I might say you have helped uncover the diabetes. But if somebody is getting big doses of steroids, the patient is otherwise thin, has no significant family history of diabetes, then we'd say this is steroid-induced diabetes. But my experience has been where we had to use steroids for autoimmune disorders, and sometimes you have to use a fairly high dose, the blood sugar always returns to normal within a week or two of coming off of the steroids. There are occasions where you're looking at things a month or two from the discontinuation, but that's not common. So most cases, they should return to normal.
Sir, because of these, after affecting with COVID, mostly they are affected with diabetes also, sir. Some of the cases are there, sir. So for those people, what is the drug of choice, sir, for diabetes? In some articles, I read that some drugs are contraindicated and some are ineffective. I read like that, sir.
So, first, I need to tell you my experience in that is limited, but this is how I approach it. The biology is the same. If your insulin levels have become low, whether you are measuring the insulin level or you are measuring the C-peptide levels. If they are low, if the patient is skinny, then that patient needs to be on insulin probably for a very long time. If the patient, if the patient is showing signs of non-insulin dependent diabetes, any drug that you use should work, including metformin. But I'm saying my experience is limited in that. I would treat the patient like any type 2 or any type 1 diabetic in that case.
Okay, sir. Thank you.
Thank you.
Good morning, sir.
Good morning.
Dr. Amir Amarao.
Oh, hi.
So my question is to you is, sir, why diabetes and hypertension is a chronic disease? Why we are unable to cure the disease permanently, sir?
Well,
Because I feel as I've been working in hospitals, it's wantedly businessly they made like this, because so many diseases they have controlled permanently. So many chronic disease, so many we have seen so many virus attacks also, polio, so many we have controlled. But why this diabetes and hypertension permanently made on public and doctor relationship continuingly? He has to go to hospital, meet the physician, continuously he has to take the medication. What do you tell on that, sir, in your experience?
Yeah, I tell you, when I grew up in India in a small village in Guntur district, we had probably less than 1,000 population in the village. We had one person with the diabetes. The entire village were farmers. And this one is a cousin of my father, who is not farming actively, but he was a grain merchant. He was the only one that had diabetes. So move the clock 20 years. And about now 20 years ago, when I visited the village, people younger than me, much younger than me, nearly blind, can't walk because of diabetic neuropathy, have kidney problems, and they all have a scooter, a motorcycle, a car, or something like that in front of their house. Another example, my father built a small temple on the other end of the street, and I was going to walk to the temple, and here comes my nephew. He said, "Uncle, you can't walk that way. Just get on my bike, I'll take you." I said, "This is just a small street from this end to that end, which is probably no more than 200 meters. So what has happened is the caloric intake has increased a great deal. The physical exercise has decreased a great deal. And so the diabetes has become a disease of poorer sections of India, the villages particularly. About 50 years ago, I was reading a textbook of medicine where they talked about in United Kingdom, diabetes and obesity were a problem of the lower class, because the lower class people were eating the potatoes, the pasta, the rice, etc. And the upper class were eating the high protein, low carbohydrate. They were able to attend gym, this, that. So that has come to India now. And the same thing is happening in China. Until a phenomenal switch happens in the diet, exercise, and our way of living, I don't think the diabetes is going to go away. And the other thing is, if we go into further genetics, when we all lived in the caves, when we had one meal every week or maybe twice a week, those that were able to eat and turn it into fat were the lucky ones. They survived. They had a better chance of survival. So what happens? Those genes got passed on to the survivor, the next generation or next generation. So now we got plenty of food, particularly the starches. Those of us that are able to eat and keep it, store it as fat, they were very desirable 6,000, 7,000 years ago, but those now are the undesirables that are getting fat and developing diabetes. So I don't think there is any cure anywhere in the near future. It would be nice if somebody could work on it. And the hypertension has a multitude of causes, not one single cause. And even that affected by diet, exercise, and the age, it's going to be tough. I hear you. If we can cut back on the need for doctors, nurses, hospitals, and the quality of life will improve, definitely. But I don't see that happening anytime soon.
Yes. Thank you, sir. One more question is, sir, so many different virus has been attacking people, sir. Like, means it may not be there any cholera or masuchi or so many diseases in India and globally. It may not be there for not more than 1 week or not more than 20 days. But why such a COVID is being continuing and affecting the people, sir? I feel is it a natural virus or someone made virus? What you say, sir?
Not being a virologist, I can give you my 2 cents worth. I think, you heard the name coronaviruses.
Yes.
The COVID belongs to that group. The similar group to viruses that cause common cold, etc. But this virus probably was circulating in the bats for thousands and thousands of years. And once it jumped the species and attacked the humans, able to attack the humans, and since then many other animals, because we are not exposed to it previously.
Okay.
The humans as a group don't have the immunity against that virus. So it's a fresh virgin ground for the virus because nobody has seen it prior to 2019 or end of 2018. It's like everybody is susceptible to the virus. Virus does what it does best: find a host, multiply, find a host, multiply. And so that is why we are having so much trouble with it. And virus, like anything else, has mutations, many mutations. So as the mutations come, there comes a stage where the mutations are so many, now it becomes a different strain, and that can be more disastrous down the line. So luckily, so far, the Omicron, which has, I heard 37 to 50 mutations, it is spreading very fast, but it is not causing as much severity either as the alpha variety or Delta. So it will come back, in a different shape or form, maybe, or a different virus will come back. If you look at all the viruses that came from Africa, China, and other places, they will circulate, recirculate, jump species occasionally.
Okay, sir. Thank you, sir.
You're welcome.
Good morning, sir.
Good morning.
Sir, I have a question. If a
Yes.
patient comes to you with a condition, and if we say that Ayurvedic medicines are having lesser side effects than our allopathic medicines, so do you recommend them using the Ayurvedic medications or not? How do you deal with them?
Simple. If the patient come to see me and say, hey, look, I used a different system of medicine that worked for me. I had no side effects. I'm afraid of taking the Western medicine. My way of looking at it is, I don't know enough about these medications. And if you truly believe that is the medicine for you, you need to learn more about it and take your chance. This is where you, I, and other people like us make a mistake. Because we don't know what Ayurveda does. We have been trained in the Western medicine. So we say, there is no proof that the medicine works. So this is the only one that you should be on. And I strongly recommend you take it. And it does two things. Number one, the patient, I don't even know why the patient come to see you, because he has a little bit of doubt. He wanted to test you or talk to you. And he is sold on the medicine, Ayurveda. So changing his mind is not that easy nor important. Your job is instructing the patient about what you know. If you have knowledge of that Ayurveda medicine, you can discuss honestly good and bad or side effects. But if you don't know, I'll say, hey, look, Lakshmaya, I don't know anything about this medicine, but you have to talk to that particular practitioner and follow what they say. But if you want to come back and talk to me, you're always welcome to. We often fail to welcome them back if they change their mind. We treat them like they are the traitors, and we don't want to give them another minute of our time. And that is generally where the problems arise. Am I making sense?
Yes, sir.
I would even ask the patient, I understand you like Ayurveda, but please answer this question. What was the reason you are here to talk to me? Did you have a doubt about this medicine or that medicine? What can I do to help you? So suddenly you made a new friend that understands you are patient and willing to listen to him. You might say, but I didn't give him the right medicine. Right medicine by what standards? If you are an Ayurveda practitioner, all the medicines that you and I are giving are all, well, you don't know, some chemicals that somebody made. They have 7,000-year history or 5,000-year history. We barely have 200-year history. Am I making sense? So we are holding on to these textbooks of pharmacy and medicine and say, this is the only right thing. I'm saying Maybe not. Because what the patient believes in is the most important thing. That's why when a drug comes into market, it has to do much better than a placebo. And the placebo effect is 8%. So if your drug is showing 10% efficacy, that might pass, but it is barely better than a sugar pill. But you and I are supporting that.
Sir, as we Indians, we have few home remedies for minor ailment management. So if, for example, patient has some gastric problem by eating a non-veg the day before night, and do you prefer him to go with the Pantop, or you can do it by your home remedies? What do you prefer, sir?
Well, used to be before we had these medications, they had maybe some carbonated water, like the soda, or whatever was available. So they burped a couple times. Their acid regurgitation was under better control. So it doesn't matter what works, because this is a temporary problem. We don't want to give a long-term medication. If calcium carbonate works, so be it. I don't know what is the trade name there. Here we call it Tums or Rolaids, but if they have something like it, or even a liquid form, that would work. Gelsil, I remember, used to be something I used to take or give to patients. So it only happened once. I just want to treat it once. If he has some pantoprazole and take it, or if he got that calcium carbonate, whatever works.
Okay, sir. Sir, in what areas we as a clinical pharmacist should get expertise, sir? Because here in India, the system of medicine is different when compared to the other countries.
Yeah. I don't know if I can give you an expert advice on things I have really not much knowledge of. Don't know. I think there would be some possibility where some of you might be able to start a pharmaceutical company or a distribution system, where once you have some weight to the system that you start, you might be able to negotiate with patient groups, the insurance companies, the doctors, the hospitals, etc. But alone, you can't change any system. And the system should be aimed to help the patient. That is when it is likely to succeed, not to help the pharmacy group or the clinical pharmacists.
Okay, sir. Thank you, sir.
You're welcome.
Sir, good morning, sir.
Good morning.
Sir, can you please tell me the treatment for tachycardia in asthma patient?
Oh, interesting. Well, if the tachycardia is because of asthmatic attack, treatment of asthma is the treatment for tachycardia. You don't necessarily need to treat the tachycardia, and you don't want to, because of the shortness of breath, the anxiety or the fear that is happening, the heart is beating. That is just a normal response. If, on the other hand, if you develop a tachycardia first and then became short of breath, that is a different issue you're looking at. Then you're talking about, depending on the age of the patient, whether this could be a reentrant tachycardia, as in WPW syndrome in somebody in their teens, 20s, 30s, 40s, etc. Or if it is a much older patient, whether they're having atrial fibrillation or atrial tachycardia or even a ventricular tachycardia. So it all depends on what you can see on the monitor or on the EKG. If the patient has asthma, you give the treatment with your inhalation solution, the breathing gets better, and in a few minutes, I'm saying a few minutes because the treatment is going to cause more tachycardia. So in about 20 minutes or so, if the tachycardia is better, then you got the answer. I don't want to treat the tachycardia in that patient.
Sir, if someone gives beta blockers for asthma patients, sir, so what can we treat, and instead of beta blockers, what the medicine can we give to the patient, sir?
Okay, that's good. So there are beta blockers and more beta blockers.
The beta blockers, it precipitates asthma, no, sir? And
Well, yeah, right. So depends on what is the reason for beta blocker and what kind of beta blocker. If the beta blocker is cardioselective, like metoprolol, then, and if the patient has angina or tachycardia, that was the reason to give the beta blocker, then I look at it as that is an important issue where you wanted the beta blocker, and it may not be the beta blocker that precipitated the asthma. Maybe it might have exacerbated the asthma, but not caused it per se. So you want to know why they are on the beta blocker to begin with. If the patient has angina and it has become stable after the beta blocker, had an open heart surgery because of coronary artery disease, and they were told they need the beta blocker all the time, that is the patient I don't want to change if they are on a selective beta blocker, but treat the asthma. We treated any standard ways to use bronchodilators, steroids, whatever else you generally use.
Thank you, sir.
You're welcome.
Good morning, sir.
Good morning.
Today in our session, my question is, most of our physicians are prescribing pantoprazole irrespective of diagnosis and age to all the patients. So how extent it is rational, sir?
It's not. I mean, like any medicine, pantoprazole can have benefits, can have nasty side effects, from osteoporosis, bacterial overgrowth, fractures, etc. So if there is no reason to give pantoprazole, the question is, why is it being given? Is it a kind of on a rubber stamp that pantoprazole is a part of the treatment for something? I don't understand that. That I would not consider that as a good practice. I don't know besides that how you can make a licensed practitioner stop it. But if you approach the doctor privately, politely, and say, can you please tell me why you are using, maybe they'll be able to tell. That would be a poor choice.
Sir, is this going under practice even in abroad countries, sir?
Pardon me?
Is this also going under practice in abroad countries, sir?
I'm sure there is some degree because people are people everywhere. It may not be pantoprazole, it may be something else. So some people get in the habit of doing things because they feel it always worked for them. Again, there is no science behind it. If I give everybody the same medicine, you don't need me, you just need my rubber stamp signature. Somebody can write the damn things. So there need to be more to it than that.
Thank you, sir.
You are.
Good evening, sir.
Good evening. Good
thank
morning.
you- First of all, thank you for providing this opportunity at this time of our. I like to
You're welcome.
ask is, what are the major interactions you have seen upon discussing with pharmacists? Drug interactions.
Drug interactions, you know, I should say there is always a little bit of conflict between pharmacists and physicians, both being licensed and professionally trained. There's always a little bit of a turf battle. This is my area. What the hell are you doing there? So that is always there. And there are times where I might call a pharmacy, talk to the pharmacist and say, hey, I need something for this patient. These are the constraints. Call me back with what you have for this condition, for this. How often have I done that? Maybe 10, 20 times in my career, but not afraid to ask for help, not afraid to say, hey, I need something to do this, but the guy don't have money, come up with an alternative or how you can help this guy. Or see if you can get permission from the insurance company to use this medication because of this and this reasons I need this. Or, you know, it's something similar. So this is what it takes. Number one, you need to, you know, whether it is a doctor or a pharmacist, you need to have a certain amount of self-respect and confidence. I know what I'm doing, I'm okay. And they generally know what they're doing, they're okay. So I'm not afraid to approach and ask or question. But, you know, the countries are different, social norms are different. So I can understand that. But I would be saying I'm not afraid to raise a question or a topic.
Thank you.
You're welcome.
A very good morning, sir. I'm
Good morning.
from second family. So I want to ask why only methyl dopa is given during pregnancy? Why not others?
Can you talk a little slower? My hearing, I need have you ask me that again.
Sir, why only methyl dopa is given during pregnancy? Why not other drugs?
I apologize. I still don't get it.
So why only methyl dopa is given during pregnancy, not other drugs?
Methyl dopa given for pregnancy, for hypertension. Is that what you're asking?
Yes.
Okay. It has been a long time since I used methyl dopa. The only thing I could think of is it probably is given for accelerated hypertension. Probably there is less fatal effect, maybe. I don't know. Not my area, and I have not seen that in a very long time. And if I write a prescription for methyl dopa, our pharmacists in the area won't find it. They'll have to order specially from a much bigger center somewhere to get it.
Thank you.
You're welcome.
Sir, can you please tell me the fever management in liver cirrhosis patients, sir?
Can you step closer to the mic, please? Yeah.
Can you please tell me the fever management in liver cirrhosis patients?
Well, that becomes a bit more complex. If somebody with the cirrhosis has fever, the number one question is whether they have infected ascitic fluid. So if the CBC and the chemistry are showing indication of infection, if the patient is stable, I probably would want to have ultrasound guided paracentesis diagnostic so we can check the fluid for WBC, for cultures, and then start the appropriate treatment. That would be, but the same patient could have pneumonia, could have urinary tract infection, it could have infected wounds. I mean, they could have all the problems like everybody else. And one thing that stands out would be whether they have infected ascites.
Thank you.
You're welcome.
Good morning, sir.
Good morning.
So my question is, in older patients greater than 75 years of age, if they are diagnosed with hemorrhagic stroke, what is the appropriate therapy to initiate and save the patient?
Okay. Well, the hemorrhagic stroke depends on if there is shift in the intracranial shift, or if there is just a minor hemorrhage. If it's a minor hemorrhage, probably they can be watched. If it is a significant hemorrhage, whether they're talking about doing a craniotomy to drain the blood, then it becomes a different issue. My expertise is limited, being in a small town with that. But if it is a large hematoma, intracerebral hematoma, that patient need to have a drain put in and the bleeding stop right away. As far as the control of blood pressures, something like a nicardipine might make a difference. Either I can't think of the name of the antihypertensives we have used in the past because we always send them to a tertiary care hospital. And I am in a small town practice. I can't think of the names of the drugs that have been used. But nicardine or one of the calcium channel blockers seem to be what comes to my mind. Okay.
I've got another question.
Yes.
How to normalize the vitals in hemorrhagic stroke in blood pressure and diabetes patients?
If you don't mind, remove the mask and talk to me, please.
How to normalize the vitals in hemorrhagic stroke in blood pressure and diabetes patients?
If, I think almost always you think in terms of higher blood pressure in those patients. Whether they have diabetes or not, it is immaterial at that point. So you will, if the patient's hemorrhage is being taken care of, from nitroprusside to calcium channel blockers, whichever way you are able to control the blood pressure, you would. But again, my expertise is limited in that area.
Thank you, sir.
You're welcome.
Good morning, sir.
Good morning.
How to treat chest pain in angina after given sublingual nitroglycerin given therapy, sir?
Take the mask down and ask me, what do we do after nitroglycerin for angina?
Yes.
No, ask me one more time. If you don't mind, remove the mask so I can hear you better.
How to treat chest pain in angina after initial sublingual nitroglycerin therapy, sir?
Okay. So if this is, if this is the first time, you don't even know if it is just angina pectoris or they have unstable angina or they're going to have a myocardial infarction at that point. Yes, you are given the nitroglycerin, the chest pain went away, and you want to do serial EKGs, you want to do serial enzymes to make sure they did not have a heart attack. And after the 3 EKGs and 3 blood works, then if the patient is stable, you want to put them on a treadmill to see what is the extent of the problem. If they have a severe problem, are they able to walk on the treadmill without major changes, or how bad the changes are? So then you can stratify whether that patient is going for a cath or going home, and this time probably on a beta blocker. What is happening to the high, if they have high blood pressure or not, if they have diabetes or not. So we're only treating the nitroglycerin the angina with nitroglycerin, but we want to know what else are the causative factors. We also want to know the lipid status, renal function, all that. So if it is angina, if it does not need a heart catheterization because the changes are minimal on a treadmill, that patient is going on a beta blocker, a prescription for nitroglycerin, a prescription, and the lab work that will show us whether the patient need what kind of treatment for lipids. Okay.
Why not a curable therapy?
Why not?
Why not curable, sir?
Cure what?
Angina.
There's no cure for angina. So you want to, if the cure would be if they have a blockage around the heart, coronary artery, you need to know that. To know that, you need to do a stress test and follow that maybe with an angiogram. And if there is a blockage, you want to do a stent or do a open heart surgery, whatever is indicated. That would be a cure in a way. If they don't need that degree of treatment based on the stress test, now you have a chronic stable angina. If the treatment does not have any serious complications, we could all be doing angiograms, angioplasties, and open heart surgeries, but there is a certain amount of mortality with these procedures. So you don't want to necessarily take everybody to the cardiac cath and see if we can fix that.
Okay, sir.
Okay.
Good morning, sir.
Good morning.
Suppose if a patient is quite far from the medical services and he has attacked with a sudden stroke, and we know that the window period is only 4 hours, what can we do to keep him stable until he reaches the help?
Okay.
Or further stroke management?
So depends how far he is from medical help. that can give him thrombolytic.
Hemorrhagic stroke, sir.
Oh, hemorrhagic stroke. You know, those are difficult philosophical questions sometimes. What can you do if somebody has a hemorrhagic stroke in a far out place where there is no medical care, no transportation? I don't know any which way you can do much with that. You pray and you sit down, you hold hands. If you have other ideas, I want to hear.
Or ischemic strokes. If it is
ischemic stroke, then again, you can ask them to chew some aspirin. That might help a little bit. But the treatment, by the time 4 hours has passed, you are losing brain tissue. And 6 hours, 8 hours, 12 hours, every hour takes on a more permanence to that destruction. So that is a difficult problem. You know, at least with a ischemic stroke, some of the smaller centers, smaller towns may be able to give thrombolysis if they can do a CAT scan first. I don't know how often those facilities are available in India at this time, but I don't know of any other way to stop that. The only thing, if I am in a position there and I find somebody has a stroke and it is ischemic, more than likely, if somebody has a low molecular heparin or a heparin, that may be a possibility to get another 4 to 6 hours of, you know, that it may not extend further, but it is not going to do anything for the first stroke. So the concentration should be get him to a doctor or a medical center as soon as possible.
Thank you.
You are.
Good morning, sir.
Good morning.
Sir, if a patient is having a type 2 diabetes mellitus and he is a renal failure patient, out of your experience, what treatment do you suggest, sir?
You know, for the treatment of diabetes, obviously insulin would be the drug of choice in my case, because, you know, he cannot take many of the oral hypoglycemics, and the newer oral diabetic medications are too expensive. Probably by the time they went on a hemodialysis, they're already suffering a lot financially. So for that patient, insulin, maybe a long-acting and a short-acting insulin might be the best way to treat that patient, especially if they can follow their blood sugars, finger stick sugars.
Okay, sir, thank you.
You're welcome. I should say, I'm not sure what are all the drugs available and what are the cost factors in India at this point. So
Good morning, sir.
good morning.
How do you diagnose the Wolff-Parkinson-White syndrome with the supraventricular tachycardia?
How do you diagnose
Wolff-Parkinson-White syndrome with supraventricular tachycardia?
It's not always easy, because even in Wolff-Parkinson-White syndrome, you don't always see the delta wave. If you see the delta wave, you can say, oh yes, it is Wolff-Parkinson-White syndrome. And the times you don't see the delta wave, you're thinking in terms of it's a supraventricular tachycardia, which is probably reentrant tachycardia. The treatment may not be much different. I would treat it as a reentrant tachycardia. And most of the time, things stabilize, and then you get the cardiology consultation and maybe an electrophysiology study to further define that. But once the rhythm is stabilized, the EKG might show differences whether there is a delta wave or not.
Sir, from your experience, what advice do you give for us in treating a patient?
With what?
Not with what, sir. I mean, from your experience, what are all the advices would you give for us in treating a patient?
I mean, with the WP, with the Wolff-Parkinson-White, or any patient?
Or any patient, sir. What are the primary things we need to consider?
Okay. So there are as many patients there are. I mean, every patient is different, and they have different issues every time they see a different practitioner at a different town, etc. So number one, I want to convey is I am ready to help. That's number one. Number two, I am very honest and open. If somebody says, do I have cancer? If I know that they have cancer, I'll say, yes, you do. If they ask me if they have long to live, if I know the answer, I give the answer to them. So number one, open, honest, and able to tell what is wrong with you. The day I am able to open up and tell you, hey, look, you have this heart problem. If you do everything right, you have a good chance you live many more years. But if you don't take care of this, this might shorten your life. I have had many of those conversations over the years. Patients respect you and thank you, and they stay with you. They come back for more advice. So, but sometimes the patients or family members will say, I don't want my dad to know what's wrong with me or what's wrong with him or her. I ask why. If there is a good reason, I won't push my opinion on them, but if they ask a question, I answer. So one is being honest. Number two, give all the available answers and what the options are. Don't make the patient feel like he is an idiot because he is not following your advice. The moment we do that, and I have done that myself, the moment we do that, they're not coming back to see you. They don't want your advice. They really don't want to deal with you.
Thank you, sir.
You are.
Thank you, sir.
You're quite welcome.
We are ended with the questions, sir.
I'm sorry, you're done with the question. That's good.
We are done with the question.
That's good.
Thank you, sir, for sparing your valuable time for your students and making them learn a few things what have been experienced by you in your journey of your career.
Thank you.
Thank you.
Thank you. I enjoy talking to them about my experiences.
Yes, sir.
It's good. I hope, if nothing else, they know how the doctors in other parts of the world work.
So on behalf of Chalapati Institute of Pharmaceutical Sciences, I thank Dr. Kishnaya Galapati garu for sparing his valuable time for giving a good talk on this congestive heart failures and all the cardiovascular problems on this auspicious day. I thank our principal, sir, Dr. Nadal Ramarao garu, for giving us this platform for students where we have discussed. And I thank the management of Chalapati, who has given this platform for us to meet the eminent personalities through online or any other thing. Thank you, sir. Thank you so much.
You're quite welcome. Thank you.
Thank you, sir.
Thank you. Bye-bye.
Bye, sir.
Bye-bye.